So the next up is the ECG for all. This is a very, very, very crucial part of our sessions here today. It's also very, very important to us at the Limi hospitals. At every point in time, a patient comes with chest pain, do an ECG. Patient comes with recurrent symptoms of PUD, do an ECG. We always prefer to err on the side of caution. So for the next session, we're going to have 3 doctors anchoring it, Dr. Iseko, Dr. Olalekan, and Dr. Inuwa. Please put your hands together.
So everybody please come back, let's start. Remember, pen and paper, writing. For now, for everybody that has half knowledge, forget your half knowledge. Like Prof said yesterday, you need to learn, relearn, and unlearn. So for the purpose of this, just scrap that half knowledge you may have. Just for the purpose of this, just scrap the half knowledge. And those that have hyperfalutin stuff, you know how to use this thing and calculate axis to 24 degrees. For now, scrap it. Just listen to the one I will teach you. This one will benefit you. What I'm teaching you is ECGs for everyday clinical practice. I think everybody has scanned and kept it. Scan it, keep the save the link and share it with your workplace. Beautiful. All right. ECG is ever evolving. ECG, nobody is a full master except maybe Prof. Every day in our practice in cardio care, with the amount of patients that are cardiology plus patients, there will be an ECG that's, you know, we'll put it there. Dr. Olalekan, what do you think? Dr. Inuwa, what do you think? Yes, what do you think, Dr. Iseko? Back and front. At an ECG. So it's the same everywhere then. We're always looking. So nobody is a mountain of knowledge. And so that's why we have extended an arm of fellowship. On your tables, you will see a QR code to join our WhatsApp community. And it's just simple. If you see an ECG that you cannot interpret or you are not sure of, snap it, put it on the WhatsApp group, but first, as you put it there, interpret it. What you think that you saw, you must interpret. Then anybody else from the WhatsApp group can now comment. All our cardiologists are there, and other people are there. And even, in fact, what happens is that somebody amongst us will answer it and we'll just say thumbs up. Okay? So scan the WhatsApp code, and then you can also get, it will be easy to share the slides with you, easy to share the links with you. All the slides of the lectures throughout the ACS will be sent to your email, and will be on YouTube likely from next week, so you can rewatch them. From previous ones will be there, so you can watch them and rewatch them in your spare time. Instead of watching them beat Chelsea over and over again, you can watch something else. All right, fine. All right, Mr. Nakala, my slides. All right, my name is Dr. Iseko. I'll be talking about ECG with my colleagues. These are our requirements. If you don't do this, you will not succeed. You must write. You must write the formulas. There are some formulas you must cram. There is no shortcut. I'm sorry. There are a few things you must cram, and there are things that you must write. Now, the easy way is this. Once you have written out the formulas, whenever we bring out a new ECG, just open your book where you wrote with your own handwriting and work with it. In the jotter that you have, I'm sure you know that jotter is invaluable. I hope all of you know. Hope you did not skip it like a marriage jotter. Somebody wed somebody. Inside that jotter, there is a quick reference ECG interpretation guide, 2 pages, very for quick reference. So everything I'll teach today is summarized in 2 pages. That's number 1. Number 2, there is a quick reference chart to see some ECGs that are life-threatening, that if you see on your monitor, you should know what to do. So that is also there. Then there's maybe 20 plus ECGs for practice, which we will practice here today. So we'll do that. We call it the ECG for all workbook. It's all there in that your book. Somebody said they wanted to buy the book yesterday for other people. I say it's not for sale. It's just something for the meeting. So an ECG is a record of electrical activity. It's cheap. It's widely available. It is non-harmful. It can be used in detection, diagnosis, and assessment of response. Also useful in non-cardiac conditions, electrolyte derangements. So some of us, this is how it looks like this. For some people, they said to themselves that if they ask me ECG in final exam, I'll tell them, Prof, don't worry. We are coming back. All right, so some people, this is what it looks like to them. So we'll try and demystify it. So what does it mean? The ECG is simple. I play the piano almost professionally. And the piano is just simple of 8 keys or 13 keys multiplied over and over again. Same thing with the ECG. The ECG simply has these different components. P, Q, R, S, T, and maybe U. But for now, we'll just do P, Q, R, S, T. I'm going to explain this. This is the most critical part of this lecture. Once you understand this, you can deduce the remaining going forward. The heart. Yes, good. This is how the heart functions. From that SA node, that blue one, the impulse is generated. Kainjidam. Right? It is generated. It goes through there, goes round the entire right and left atrium, then comes to the AV node and gathers it. The reason why it must come to the AV node is that we want everybody to pass through customs. We don't want everybody to pass through different corners. Do you understand? So this is customs. You need to encourage me, or if you don't understand, talk, so I don't go too far. This is customs. In some people, they have abnormal pathways. It doesn't pass through there. They smuggle some electrical activity, fiam, into the ventricle, and that causes severe arrhythmias. We call that accessory pathways. But everything comes to customs. At customs, just like in current apapa customs, there must be a delay for processing. This AV node will process for 0.12 to 0.2 seconds, thereabouts. So we call that a PR interval. That delay is necessary so that you can collect everything together. Now, if you have too much money and you try and bypass that delay, you will cause trouble. Everybody must wait for their turn. Good. After it has passed through there, it now comes down through the His bundle, and then it separates right through Purkinje fibers, right, left anterior fascicle, left posterior fascicle, and down into the different parts of the muscle. So atrium, small delay, gets to the ventricle, ventricle depolarizes, ventricle contracts. Is it not very simple? Why I say you don't understand ECG? Yes, it's easy now, not so? So when that atrium is depolarizing, it happens here, P wave. Where is customs? PR segment, waiting to gather everything together. Whenever people try and bypass customs, this PR segment will shorten, and this P wave will almost touch here. Those people have very rapid, fast heart rates. They now have arrhythmias. So when you are looking at it, you also check for this customs border, that nobody is bypassing it. So the delay must be there intact. When it does that, QRS is for the ventricles, and the ventricle now gets depolarized, and the ventricle recovers here. The recovery of the atrium is hidden inside here, while the recovery of the ventricle is what we are seeing here. Okay? All of this is very important. Don't miss everything I've said here. There is no wasted word. This is very as simple as it gets. As somebody that suffered with ECG, I am telling you, you cannot get it simpler. Okay? Beautiful. Do you understand that? Very simple. Where does atrium? Atrium is represented by what on the ECG? P. Ventricle by what? QRS. Ventricle recovery by what? T wave. T wave. I said unlearn. And some of you are saying ST. You are technically somehow correct. For the sake of this lecture, delete. That is how come you cannot read ECG now. I am not telling you, you are now bringing your half knowledge. Delete. Good. Everybody that's been for ACS before can all read ECGs. You will not be different. All right, so that is essentially what happens. So let's go forward. So we have different intervals, different waves, different durations on the ECG. And we look at it this way. We look at the P wave, we look at segments, we look at intervals. Very, very simple. Now we need to know what each one is. For the PR segment, or for the PR interval, it starts from the beginning of the P wave. This is important. From the beginning of the P wave to the beginning of the Q wave. PR interval. That PR interval, this is one formula you must write. PR interval should be half to one big box, or 3 to 5 small boxes, or more technically 0.12 to 0.2 milliseconds. All of these people that are videoing, they will learn ECG today too. I will ask them a question. Better be writing. I never pay you your balance. So if you like, don't write. All right, fine. So that is PR. QRS, from the beginning of this to the, you didn't get it. PR, beginning of P to the beginning of the QRS complex. PR interval. It should be 3 to 5 small boxes. Write it down. Or half of a box to one full box. PR. Is that okay? Did you get that? If you didn't get, just raise. I will retalk again. One person didn't get. One person didn't get. PR. From beginning of P to the beginning of QRS. Half of a box, one big box. QRS, half of a box. QRS, like you are seeing here in green, from here to here, half of a box. Or 0.12 milliseconds. Half of a box. When your patient's heart rate, so you are in labor room with A and E, your patient comes now, they cannot breathe, and they say, doctor, who is doctor here? Some of you will just hide. I can't be doctor. So that you don't hide, and you can come and say, I'm the doctor, yes. What is happening? You need to understand this QRS, especially the duration. For that tachycardia, we divide the tachycardias into 2, and we're going to talk about that during ACLS. So everything I'm saying is very deliberate. There's no wasted word. If I'm telling you something looks complex, it's because it's important. We now look at this QRS. If this QRS is more than these 3 small boxes or half a box, we say it is wide. If it is 0.12 or 3 small boxes and below, we say it is narrow. Not narrow, not thin. Narrow. Wide and narrow. So, wide complex tachycardia and narrow complex tachycardia. So, in fact, you see anybody's heart rate very fast, above 130, 170. The patient is shouting, everybody is shouting. As you look at the ECG on your monitor or you do an ECG, the first thing you will go to is the QRS. After the rate, you will go to the QRS and tell yourself, is this wide or is it narrow? A wide complex is what, ma? What's wide? Huh? No idea? Hey, Jesus. Huh? More than half of a box. Beautiful. Any QRS complex that is more than half of a box, or that is more than 3 small boxes. 1, 2, 3 small boxes. When you come closer to this thing, you can't see it well again. Any QRS that is more than 3 small boxes is wide. Anyone that is less than that is narrow. Are we all together? Isn't it simple? It's simple now. Aha, beautiful. That's all I'm going to talk about that. The remaining extra stuff, sign up for masterclass. If I tell you everything now, will you refer patients? I'm joking. All right, fine. The remaining is about whether they are up or down. This QRS we are looking at, is it predominantly facing up or facing down? Up, Abi? That's all. But there's no trick question. There's no trick. Beautiful. So let's go on from there. This is another thing you need to cram, or formula you need to write. You need to write it in your handwriting. If you're not writing, I know that me and you will not be friends. Because at the end of this, you will not read ECG. It's not. I'm not cursing you. I'm just telling you. This is just how it works. And I've been teaching it for some time, for quite some time actually. So I have narrowed down to this formula. So you need to cram this one or write this one down. These leads that we put together are leads that are looking at the same part of the heart. So for example, these are Supreme Court judges, High Court judges, Federal Court judges. One set is looking at it from this side and making a judgment. Another set is looking at it from this side and making a judgment. Are we all together? Another set is looking at it from this side and making a judgment. For us to say that anybody is correct, two people must agree. That is all. So in all these groups, for us to say that somebody has a problem in this group, two in any of these group must be there. Not across. What Dr. Okopi is looking at and what I'm looking at is relatively different. I am seeing this side, Okopi is seeing this side. So even though we agree, it's just because he's my friend. So that's not correct. So lead 2, lead 3, and AVF, we call them inferior leads. They are looking at the inferior side and they are together. We need only 2 of them. At the voice of 2 witnesses, a matter is confirmed. Period. That's not ECG. It's not simple. Have I said anything that is hard now today? Anybody? It's very simple, Abi. I need somebody to be answering me. Yes, it's simple. Okay, the leads. We have lead 1, 2, 3. We have AVR, AVL, AVF. And we have V1 to V6. Lead 2, lead 3, and lead AVF are all inferior. We are going to use it. So if you are not writing, you will not know it. Lead 1, AVL, V5, V6, they are all lateral. V3 and V4, anterior. Septal, V1 and V2. For the sake of this presentation. Okay? Is that clear? So we have written it down. It's very simple. These are just basic formulas. There's nothing there. Only for you to understand that things are looking at. Because when they teach us ECG, then we come back to the main thing. We see the whole thing like this, jaga like this. Then we are back to square one. Everything will be unraveled today. So, at the first ACS, what I thought was 13 steps. Now, we have brought it down to 6. Because people were not carrying everything. So now it's 6. Number 1, identify the name and the calibration. Number 2, rhythm and P waves. Number 3, rhythm rate. Rhythm and P waves, sorry. Number 3, QRS. Number 4, ST. Number 5, Q waves. Number 6, T waves. Simple. That same P, QRS, T that we saw. Very, very simple. There's more stuff, but don't worry. Focus on this one. Okay? Are we all together? Very simple template for reading it. First of all, make sure you are reading the correct person's ECG. And that it is done properly. Don't move stuff on the wrong ECG for the wrong patient and kill the wrong patient. So check that you are reading the correct person's ECG. Number 2, check the rates, the rhythm, and the P waves. Number 3, check the QRS. Number 4, check the ST segment. Number 5, check Q waves. And number 6, check T waves. Very simple. Now, let's get into the meat. See why I told you to stand up and stretch? Everybody's quiet. People are further maths. So let's go step by step. Number 1, identify the ECG. Identify the ECG. So check the correct name and check the standard. Most ECGs are normally calibrated. Very important. Please do not rely on the automated ECG finding. A lot of people have killed patients. They just see that thing just come out and say, so, and they just start moving. No. Please, don't rely on it. That's why you are here. Please, I take God beg you. Check standard. This is the typical one. The typical. So just check that this is written there. It's typically at a small corner of the ECG. Any ECG that you have is there. You just were not seeing it before. Now that you know, you will see. Okay? So check that it's correct. Otherwise, you will have wrong interpretation of everything. So just write this one down. Number 2, check the rate. Check the rate. How do we check the rate? Very simple. We go from peak to peak. Go from one peak of QRS to another peak of QRS and count the number of big boxes in between. When it is only one big box in between, we do 300 divided by the number of big boxes between the RR interval. Most of your monitors will give you automatically, and they are relatively correct. But still, it's good to know it. 300 divided by the number of big boxes in between. So, 300 divided by 1 is what? Divided by 2, 150. Divided by 3, 100. 4, 75. 5, 60. 6. People don't know math again. The one we know right here, you don't know. 300 divided by 6 is what? 50. 300 divided by 7. We don't enter corner. Like 33, 34. Okay, fine. Beautiful. So I'm going to do some example. Where is my microphone person? I need microphone people. Oh. Jude. Bia. I called his name. He's not even here. All right. What is the rate? See why we are doing this? Because normally when they finish teaching us ECG in medical school, even as residents, when they finish, nothing is to enter. Nothing. I will tell you a secret. Let me tell you where I learned ECG. You want to know? Should I say it out loud? Maybe I should not say it out loud. I learned ECG on Wikipedia. Wikipedia first. Before I now went to go I studied other things, so don't think I'm reading for Wikipedia. But some basic things. So what's the rate? I can see, yes? 120. How do you arrive at 120? 2 divided by 2.5. Beautiful. Oh yeah, come and take certificate. Where is certificate? Give him. You are a cardiologist, that's all. There's nothing more than that. Only need a special stethoscope. Okay, what's the rate? Don't say it out loud though. You will raise up your hand. Let me know that you have liver. Yes? Talk now. It's better to talk. Yes, give her. Yes.
50.
50. How did you arrive at 50?
There are 6 big boxes.
Hey, my dear, give my ECG. Biko. My ECG.
I know.
Kilo day. You're spoiling my message.
There are 6 big boxes between
6
the
big boxes.
2 QRS complexes.
Okay, look for one that falls on a line. So let's say 1, 2, 3, 4, 5, 6. 6 more or less. So 300 divided by 6, Abi? 50, something like that.
I contest it. I'm contesting the answer.
Please, go ahead, sir. When you go to the screen, you can't see anything again. You have to come back.
I'm contesting it. There is no speed.
No, just for argument's sake. Just for teaching sake.
There is no standardization.
No, we assume all ECGs.
There is no standardization.
All ECGs.
No, I don't agree.
All ECGs here for standard. Just for teaching sake.
I'm waking them up. You don't just jump into something that you
exactly
see. You must scrutinize it. What is the speed? Before you can say this is the answer, you must check for the speed.
Yes.
Any ECG that is not due, no speed, no voltage,
you will make a mistake.
Any interpretation is rubbish. Big rubbish. Thank you.
Thank you very much, sir. Please, let's give me a round of applause. Hey, my professor. Again, we are coming to that point 1. Check the speed and the calibration. But for the sake, I cut all of those things off. You cut off the names. All right, so somebody got it very well. Isn't it very simple? You already did ECG now? For now. All right. Okay, what about this one? Gang. Yeah, raise your hand. Give this man, yeah. Yes, him. No, that head. Yes. He looks very serious. Go ahead. You can do it. I believe in you. Yes, you can.
Okay, 300 divided by 1.5.
Oh, how about now? Today. Is it 1.5?
Let's say by 1.
What, maybe, yeah, 1.5. Let's call it 1.5 for argument. So what did you get? 225? Sound like 225 in my head. Huh?
Yes. 225.
225. Beautiful. This is an emergency. Just know this is an emergency. You see this one, you don't do anything, that patient is dead. You don't even have time to call me. So you must know this one. Is this QRS wide or narrow? Remember, I explained it very fast. For that QRS, is it wide or narrow? Why do you say it's wide? Maybe like okay, talk now. Give somebody to talk. Anybody that is looking tomorrow, good.
It's more than half a big box.
It's more than half of a big box. So let's assume we started from. Sorry, I can't see this thing when I come close like this. I think this is a start. Let's assume we started from here. It ended somewhere here. The box is supposed to have ended here. So about 4 small boxes. So that is a wide complex. Automatically that changes what you are going to do for this patient. It changes exactly. You're going to learn it. Don't worry. Today. ACS graduate, sign your name. All right, we are done with rates. Simple. Number 3 now. Let's check the rhythm and the P wave. Rhythm and the P wave. Even though you know ECG before, just be following this. Check the rhythm and the P wave. And for rhythm, there are 5 questions you should ask yourself every time you see ECG. And when I get confused, which I do, sometimes the thing can just be, I come back to the basics. I come back and ask myself these very simple things. Number 1, are all the RR intervals regular? Number 2, is the P wave upright in lead 2 and inverted in? This is a formula you must write. Like I said, you must write the formulas, Abi. This is one of them you must write and somehow cram. Number 3, are all QRS complexes preceded by a P wave? And number 4, which sounds similar but is different and you will see some problems. All P waves have a QRS after it. So sometimes you can have P wave without QRS after it. Sometimes you can have QRS without P wave before it. And number 5, are all the P waves similar and normal looking? It's simple now, isn't it? Number 3 now, all the QRS complexes, are they preceded by a P wave? And then all the P waves, do they have a QRS after it? And then number 5, are all the P waves similar and looking alike? These are the 5 questions we use to determine rhythm. Okay. Beautiful. It's not just this thing, it's very hot. Okay, are we all together? Now let's start answering. Is this a sinus rhythm or not? Oh yeah, where's my person? Give somebody mic. No, don't give cardio care people. They're supposed to know it. If they don't know it, it will be a haba. Come on. Yes, give him. Yes, go ahead. You can do it. I believe in you. Number 1, don't worry, just be saying it. Start by saying it.
The question is
it normal sinus rhythm or not? So number 1 question is what?
It is normal.
No. Let's go take it step by step. If you start like that, when we enter the deep one, you're not going to come out. So, the first question, are all the RR intervals equal? So, when you look at ECG, most normal ECGs will have one strip, which we call a rhythm strip. And if you look here, this is our ECG from CardioCare, one of our software. Says rhythm. So, there's normally one strip that is running through that allows you to see what the rhythm is. So, the distance between here and here, and here and here, and here and here, are they about equal?
Yes, sir.
Beautiful. Question number 2. What's question number 2? Check your notes. You have to, this is how we learn it. Is the P wave upright in lead 2 and inverted in AVR? So?
Yes, sir.
Yes. Yes is not an answer. Is it upright here?
Yes, sir.
What about in AVR? Is it upright or facing down?
It's inverted.
It's inverted. Beautiful. Question 2 pass. Question 3. Hey, I've gone forward though. Question 3.
Okay.
Are all the QRS by P wave and P wave QRS? Is there any P wave that does not have a QRS after it? Let's look through. PQRS, 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 like that, Abi? Is there anyone that does not have QRS after it?
No, sir.
No. Is there any QRS that does not have P wave before it?
No, sir.
No. All the P waves, do they look alike or similar? Like they came from the same father?
It looks similar.
They look similar. So we'll now say normal sinus rhythm. Okay, just so that we don't forget, what is the rate of this one?
60, sir. About 60.
About 60?
Beats per minute.
Really? How many boxes? Look for one that is close.
5.
Let's assume this one. 1, 2, 3, 4. About 4, Abi?
About 5.
75. 3 divided by 4, 75.
About 5.
4.5. Maybe 5. Either way, you are saying 5. Between 75 and 90, somehow. But we don't have to be 100% correct. You are fine. Thank you very much. Let's give him a round of applause. Clap for him, but I want that you are going to pick next. All right, fine. Isn't that very simple? We know the rate, we know the reading. We have finished reading CG now. Half. Okay, now let's make it harder. What about this one? You pick anybody you like or you don't like. Yes, thank you, sir. The person next to him was breathing hard. I know they just gave somebody else. Go ahead. Very simple. Question 1. Are the RR intervals all similar?
No.
Hey, trouble. So what's happening? Question 2. What's question 2 again? P wave in lead 2, is it upright?
Yes.
In AVR, is it upside down?
Yes.
Beautiful. Lead 2. Question 2 pass. Question 3. Is there a P wave before every QRS? Now look carefully. Take this reading strip. And look,
No.
Is there a P wave for every QRS?
No.
No, there's no P wave for every QRS. Ha! Wow. Is there a QRS for every QRS? Was there a P wave before it? Almost the same thing in this case. So we have this QRS now. We did not see P wave before it. Abi?
Yes.
We didn't see P wave before it. Even this one, we didn't quite see P wave. But this one, we saw P wave. See it here. Oh. You must see it. This small one. You must see it. It's there. So sometimes what we do in the hospital is that that's why it's better to have a computer based. We go to the computer and we increase the calibration like Prof was saying. And if you look at most ECGs, you will see this box. This box helps you to check your calibration. If you don't see the right up. Where's the right up? Okay, it was cut. Okay, so you use this box. So if you look at that, what was I saying? Calibration. So sometimes we're not sure. We increase the calibration so that anything that is small can show properly. And it can change diagnosis sometimes because you will now see all the things that were hidden. Okay, so very right. So we are saying it's not sinus, Abi?
Yes, sir.
So what is it? That is where the question is. Now, cardio care people. Dr. Chima, it's your time to shine. Don't form my hand here. If you don't know, just give me a wink so that I will just... Dr. Kopi, let's boost off now.
So it's not sinus rhythm.
Okay, when they say agree that that's...
It's atrial fibrillation.
Atrial fibrillation. Why do you say
Yes.
atrial fibrillation?
In
In atrial fibrillation, is atrial fibrillation one of the abnormal rhythms? In atrial fibrillation, there is no P wave.
the RR interval.
Yes, in
It's not
atrial
regular.
fibrillation is irregular RR interval, but there is no P wave. In this one, can you not see P wave? See P wave
so-
here. See P wave here. Even this one, I cannot see P wave. There's a small notch here. Can we see that? There's a small notch before it came. And then after the small notch, it's almost as if they did not allow the PR interval. It now slowed. Then some now came completely with no P wave. I'll get into complex. We'll leave this one. We'll come back. So that we don't confuse people early. All right. Now let's get harder. Is this sinus rhythm or not? Anybody you like. The person is boning the better. That lady. Yes. Give her. She's the one. She wants to talk. Oh, she's on the phone. Okay, give somebody now. Give anybody you like. Thank you. Don't worry, go ahead. The more you talk, the better. If you don't try it, it's in front of a patient you will try. Dr. Inuwa, Dr. Olalekan, please just stand by the side so they can see. If anybody has a very question that they are afraid to ask, that they cannot see something, you just help point. There are also TV screens. Are the TV screens working? There's one there at least that's working. So if you are that back, you can look at that TV screen. Yes. Please go ahead, sir. Which person you give?
The RR interval is sinus rhythm.
What?
The RR interval. They are regular.
They are regular, okay. Fine. Next.
The P waves.
P wave in lead 2, is it up or down?
It's up, sir.
P wave in lead AVR, is it up or down?
It's down.
Down, fine. Every QRS, is there a P wave before it?
Yes.
After every P wave, is there a QRS after it?
Yes.
All the P waves, do they look alike?
Yes.
Yes. What is it?
Sinus.
Perfect. Oh yeah, come and sign your name. It's too much. All right. Before you sign your name, what is the rate? So that we just keep ourselves. Let him continue. Let him know the rate. About 3.5 now.
About 100 and something, 105.
No, 300 divided by 3.5 will give you about 80 something or 19. Good. Beautiful. All right. Now let's get harder again. All right. Anybody that wants to try? People are not volunteering. Okay, fine. Please go ahead, ma. The people that try are the ones that next year they'll be teaching people, I tell you. Because it sets you up. We cannot do this without this. Go ahead. Go ahead, sir. Me, I don't hear you.
The RR interval is not regular.
It's not regular. So it's unlikely to be sinus rhythm. Next.
The
P wave in lead 2, is it upright?
Is upright.
Beautiful. P wave in lead AVR, is it facing downwards?
It's facing downward, yes.
Beautiful. Every QRS, is there a P wave before it?
No.
Yes. PQRS. Abi?
Yes.
So it's there. Every QRS, is there a P wave before it?
Yes.
Beautiful. All the P waves, do they look alike?
No.
No, they don't all look alike, Abi?
Yes.
This one head round, this one head be like oblong. Abi? This one head round, this one head be like oblong. This one head round, be like oblong. Abi? Yes. The same gatesman, now they do the work. All second children, they look alike. Madam, they do away match. Abi? Do you understand? Yes. So even this one that's abnormal, all the abnormal ones look the same kind of abnormality. So it's coming from a particular place. Okay? More or less. Prof. If you come closer, it gets a little bit. Okay, yes. Yes.
Is there some activity there?
Yes, there's an activity there. So in fact, there's more than one type of P wave here. There are more than 2 types of P wave. But for the sake of argument, just stick to that one. So when we see this kind of one, what we say is that they are atrial ectopics. Remember we say P wave is from where? The atrium, Abi? Speak to me. When you talk, you give me ginger. Now we can see another P wave looking from somewhere. So it's coming from another side of the atrium. Because it's coming from the atrium and it's all still passing through that customs. When it comes down, it still looks alike. The QRS all still looks alike. Because eventually they all came out through the same customs border. We don't know which car. Every car in this car park, not everybody came through customs, Abi. Some came through. But so far they have entered. We cannot tell the difference. So because all of them came, that is how it is. Okay? So we call this an atrial ectopic. So there are some that you must know. And it's in that your book as well. In atrial fibrillation, there are no P waves and it is irregular. Irregular RR interval, no P waves. QRS will look normal in most cases. In atrial flutter, it's typically regular in most cases. Yes, please.
Someone wants to ask about the rhythm.
The rhythm, just a minute. Let me finish this one first. Hold on. Atrial flutter, typically, I'm using my words carefully, typically regular. But there will now be multiple P waves, and we will see some when we start. You need to know this one. In complete heart block, it's typically irregular. And there's P wave, but they are not related in any way. Sometimes it could be regular too, and the P waves too are regular, but they are, this one is regular on its own, this one is regular on its own. Okay? But they are not related. These last three are emergencies in most cases. You need to get a specialist in. The other one is urgent, but it's not like you wake me up from sleep. Okay? Except there are other complications associated. In ventricular tachycardia, we saw them. The QRS is wide and bizarre. The rate is very fast. In ventricular fibrillation, it's just jaga jaga. And the rate is very fast, such that there's typically no pulse. You can hardly detect a pulse rate or a heart rate. That one you must shock immediately, or that patient is going to the great beyond. You are the last person before they die. You are the only person between them and death. Nobody can save you. That is why, this is the reason we organize this in symposium. Whether you are in theater, whether you are the surgeon, whether you are the person taking the delivery, and you see this, you must act. Otherwise, you are the last person that will see. And because it's typical on a monitor, you are the only person that will see. So nobody might even know what you saw. Okay. Yes, question.
Sir, in the last reading, can we say the rate is irregular?
Oh, thank you, sorry. In this kind of one, how do you say the rate, Abi? That's what you are trying to say.
Yes.
There's two ways of doing the rate. The first way and the most common way, which I will just teach for here, is to take the different RR intervals and take the average and do that. That is the simple way. Okay. The other is complex way, but let's just focus on that. So 1 is 3, 1 is 4, 1 is 5, 1 is 6. Take the average, and then 300 divided by the average give you that rate. Do we understand? Thank you very much for that question. I forgot to add that. So these are reading red flags. All reading problems should be referred to a specialist after your initial care. I have seen referral, patient with ventricular fibrillation. That is an indicting statement. For you to refer and say patient has ventricular fibrillation, I'm referring you. It's indicting. Because that paper can be taken against you anywhere. Ventricular fibrillation needs you to act immediately. And ideally, you should not be a health worker if you cannot identify that. Because it means the patient will die in your hand. It is not for cardiologists. This is for everybody. Everybody doing anything on anybody. So, when I see that kind of referral, I say, my ACS work is not complete. We still need to do another ACS. Are we all together? Fine. All right. What about this one? Hey. Please, come. Give somebody now. I saw Amaka from Venus. Go ahead. Thank you very much. Go ahead. Health tech from India. Abi?
Yes, sir. The RR interval is regular. But the P wave.
Not particularly, Sha.
Yes,
But
sir.
for argument's sake, let's just take it. Well, not particularly. Go ahead.
Then the P wave in lead 2,
Yes.
they are not upright and positive.
They are facing downwards or upwards?
They are downwards, sir.
Downward. In AVR?
In AVR is positive.
It's positive. Okay.
Yes, sir.
Fine. Next.
Then in
Is there a P wave before every QRS? So every QRS, is there a P wave before it?
yes, sir.
Yes, there's a, good. For every P wave, is there a QRS after it? Is there a QRS after every P wave?
No, there is
No. This is the critical one. This is why those questions were looking like tautology before. You don't understand. You understand? Talk if you don't understand. Let me go over. Who doesn't understand? Should I go over it again? I should go over it again. Simple. So thank you. Let me explain it. This P wave here, is it facing down or up? Down. See it now. That one, is it facing down or up? Up. And we said it should be the opposite, Abi. Now, we say every QRS there's a P wave before it. But after every P wave, this is P wave 1, P wave 2, P wave 3, P wave 4 before we now saw QRS. Did we see that? Again, P wave again, P wave again, P wave again, P wave again, before it now came here. Again, P wave again, P wave again, P wave again, P wave before it now came here. Did we see that? Beautiful. What kind of reading, therefore, is this? Huh? Thank you, sir. I'll give you a car, but I don't have one to give you. We said atrial flutter, there will be multiple P waves. Remember, it's typically regular. It could be either fast or slow. So let's go back there. If you have a patient with heart failure and you are doing all the things you are doing and the patient is still not doing well and you did not recognize this, you will not get well. Because the atrium has to pump fire 4 times before the ventricle, before that customs agree to pass one to the ventricle. Then the ventricle will contract once. Big beam. Atrium fire again, then pass one. Big beam. Do you understand? What about this one? What about this one?
Yeah. I think we need to remember some physiology. All right, in the setting of atrial flutter. We need to remember some physiology. The AV node is, because of its prolonged refractory period, is like a step-down transformer. Yeah? So it's like a step-down transformer. So if you look at this, okay, I think if you have gone back, if you look at the atrial rate here, yes, if you look at the atrial rate, it is so fast that not every impulse will cross the AV node. Because by the time an impulse is coming in, the AV node is refractory, so it blocked. But the P has already been shown. It doesn't go through. And then now comes refractory period. It's blocked, but you see a P. So AV node is a step-down transformer. Look at your lines. The high voltage, the low voltage. Do you remember your lines? The high voltage must go through the transformer before it gets light to your house. In the low lines. All right? So
if you don't understand what he's saying,
you should remember this one.
I can hear some people grumbling.
So very, very important. And then we also say atrial flutter, saw-tooth appearance. The carpenter saw.
Sir, let's leave that one first.
Okay. Okay. Because
that's why we don't understand it before. Okay, so there's something, Prof, which I want to highlight. The atrial rate. Just like we did the ventricular rate from RR interval, Abi, we can also do the atrial rate in this case from PP interval. This is like one box, Abi. From here to here, hello? Like 1.5 or something. Or one box. So this atrial rate, 300 divided by that one box is what? 300. Or if it's 1.5, 225. So the atrial rate here is 225. While the ventricular rate, what's the rate here? 1, 2, 3, 4, 5.5. So that's about 60, Abi. Beautiful. So it's almost a 4 times the rate. But let's move for that one. All right. Who is answering for me? 74-year-old man with chest pain and palpitations. He has landed in your A and E. Your CMD has called you. Hey! Maybe you went to ACS. Come here. All right. Some of you, before your patient dies, this is where your monitors. You were doing CS and you saw it, but it did not ring any bell. Today, now you will go. You are liberated. All right. Who is answering for me? Who is answering for me? Jude, give somebody sharp now. Go ahead, sir. Go ahead. Don't worry, we're waiting for you. Sekai.
Yes, sir. The R wave is regular, sir.
Regular. The RR interval is regular.
Yes, sir.
Don't call it R wave. RR interval.
The P wave is in second lead is not upright.
Yes, I think so.
And in AVR, the P wave is upright.
Anyway, for argument's sake, let's go past that one.
Then QRS waves, are preceded by P waves.
I'm happy. Dr. Aganya is working. Prof is working. Yes. And every P wave there's a QRS after it, Abi. All the P waves, do they look alike? You're not so sure. You cannot see the P wave very well.
Yes,
but
sir.
the P wave is here. It's actually there. You can see that here. Can we all see where I'm pointing?
Right.
Just there. It's actually there. Almost look alike. This QRS, is it wide or narrow?
It's wide, sir.
Wide complex tachycardia. So let's go back to our chart. Which one is wide and bizarre?
Right.
And it's typically regular. And it's typically fast. What is that?
Ventricular tachycardia.
What is it?
It's an emergency.
Emergency. Okay, fine. And this one, ventricular fibrillation, it just looks like jaga, uncountable. But before you make this diagnosis, make sure that your ECG has not disconnected from the patient. Sometimes ECG has disconnected and you are seeing jaga. You say, hey, you'll be shocking somebody. The person will say, no. You say, my friend, I let in say I want to shock you. Keep quiet, let me shock you. All right, that's a joke. All right, what's the reading here? The thing is showing clear somehow. Okay, so this is already showing. Whenever this PR is very prolonged, we call that a first degree AV block. Remember that custom that I say we'll hold it. No matter what is happening, it must not hold more than one big box. from the beginning of P wave to beginning of QRS. Remember when we talk about PR? Beginning of P to beginning of, right? Check your book, you wrote it down. Beginning of P to beginning of QRS. No matter what, it should not cross one big box. It should not turn to what is happening in Apapa now, no matter what's happening. Once it crosses more than one big box, we say there's a block there. And that block is first degree. Oh, I don't know how I moved. No, it's working back. Oh. Anyway. Okay, welcome back. That's first degree. First degree, forget about this ECG you're looking at. That's not the correct one. But first degree, PR is prolonged only. By the time we get to second degree, we have type 1 and type 2. In type 1, that's the way Olalekan likes to say. Where's Olalekan? There's one way you like to say. I like the way. Please give Dr. Iseko a beg. Let him explain type 1. In type 1, it is prolonged, just like the first degree. Then the next time it prolongs a little bit more. Then the next time it prolongs a little bit more again. Then the next time it kukuma drops before it comes back to what it was before and starts prolonging again till drop.
Okay, for AV block, so we're talking about the custom points holding the interval more than necessary. So the way we used to say it is, you have for first degree, it is just prolonged a bit and it's the same. So we talk about a husband and wife. The husband comes home late, but at the same time, every day.
And he always comes home.
At that same time.
And he will always come home.
He comes late, but at the same time, but he will come home every day. That's the first degree. Then when we get to second degree type 1 that we're looking at, what happened is there is progressive increase or progressive prolongation of the PR time till you get to a P wave that would not be followed by a QRS. So if we start from the beginning, you can see the P wave, the QRS T. Then by the time you get to the second P wave, look at the distance between it with the QRS. Then the third P wave, look at the QRS. Then now look at the fourth P wave that is at that T wave. You see that there is no QRS following it. Then you now find another P wave and you start the cycle. So what we have is husband comes home late today, maybe 10 p.m. Tomorrow, 12 midnight. The day after, 1 a.m. and the next night, he refused to come home. That's the second degree type 1.
Don't forget, welcome back.
So that's the second degree
they test the
type
wife.
1.
The wife no holler. The wife no holler. The wife no holler. Now he could not come back. Before the wife holler, now he come back again. Now he starts again.
So for type 2, the PR interval is constant. So, and the guy just decided one day he's not just coming. So the P wave, the PR interval is the same, and on the night the guy just refused to come home. And by the time you get to type 3, there is total dissociation between the husband and wife. The husband is doing his own and the wife is on her own. So they are totally divorced. That's the way to look at it.
Do we all understand that? Can we give a round of applause for Dr. Iseko? It's very simple, Abi. First of all, if they come home by 11 o'clock constantly, type what? Type 1. Second degree, type 1 or second degree, what also happens? It comes by 11, comes by 12, comes by 2, then it doesn't come at all. Then it comes back, they don't holler, it come back again, start again. 11, 12, 2 before. Type 2 or second degree, what happens? It comes back home at the same time, but occasionally, it just don't go come. Unpredictable sometimes and sometimes predictable. Type 3, no arrangements, they meet in the air. Abi? Beautiful. So that is heart block. Okay, so this is example of a heart block from one of our centers. Typically, most times, they need to have a pacemaker. You must recognize it because they need to have a pacemaker. Step 4, QRS. Remember the QRS, this beautiful complex, we are entering it now. All we need to know in QRS is whether it is wide or whether it is tall. That's all we are doing about it. The remaining, leave it. Leave it for me and Prof to be arguing. This one is just wide or narrow. If it is less than 3 small boxes, we say it's narrow. If it is more than 3 small boxes, we say it's wide. If the voltages are less than 1 big box, that 1 box is the big box of 5 small boxes. It is low voltage. If it is taller, it is more taller than 5 boxes, we say it's large. It's tall, sorry. Very simple. There are more technical things, so those of you technical people, sorry, just calm down. Forget that one. If you know, if you're not there here, so just collect this one for now and get where would they go. So narrow and broad, and we use narrow and broad mostly in the setting of tachycardia and the setting of heart failure. In people with a wide complex heart failure with ejection fraction that is low, they need a CRT. In people with a narrow complex QRS with ejection fraction that is low, less than 35-40, they need an ICD. But all of them with 35 to 40 class 1 indication need a device. Those with narrow complex less than 3 need an ICD to prevent them from suddenly dying, and those with wide complex need a CRT, resynchronization of the heart. All of that, we do that commonly in cardio care. I think we are doing an ICD this morning. That's why Dr. Dafe is not here. He should have finished by now. Okay? Then the height. Let's go. Now QRS, let's enter QRS a little bit. I need to teach you this. The reason I have to teach you this, sorry, this is complex, is because there are certain types of heart attacks that do not come just with ST elevation. They come with a left bundle branch block. So you must understand this left bundle branch block. Patient comes with pain, and this is how their something looks like. We have a mnemonic which is called William and Marrow. In right bundle branch block, Marrow, R, Marrow. In V1, it looks like an M. R-O, Marrow. You was wondering how I'm spelling, Abi? M-R-W, Marrow. Right bundle branch block. This one, if you see a new, somebody was ECG was fine before, then now they came with chest pain and you saw this one, they're having an MI. Don't say, oh, there's no ST elevation like before. No, this is an MI equivalent. In this one, W-L-M, William. Okay? Till tomorrow, I see easy to remember because sometimes I see this thing, I'm like, I'll say William, oh, okay, this left. Marrow, this is right. Okay? Again, V1 and V6. V1 and V6. First thing about bundle branch block is that the QRS is prolonged. Now the QRS is prolonged. In V1, it is more upright and it has this M and W. While in left bundle branch block, QRS is prolonged, but the M is in V6, William. Okay? Is it very simple? Not very. Not very. Let's look at this one. Let's now make it harder before it becomes simple. What is happening here? The QRS is prolonged here, not so. It's a little bit more than 2 small boxes. But is this Marrow or William? People are quiet. V1, is that M? V6, is that like, well, it's not really W, but we call it W. W, Abi? So, what is there, right or left? Right bundle branch block. You have that. You sign it. They pay you your money. Put your name, ACS certificate. I'm joking, no. Before Prof will report to me. Okay. Are we all together? And all together. Let's go back again. We are looking at anybody that has a wide QRS complex. In that wide QRS, we now go and we look at V1 and we look at V6. These are among over 30,000 ECGs that are in our hospital's record. No, should have reached 50,000 by now. V1 and V6. Okay? In V1, we can see like an M. And we call that right bundle branch block. If the left bundle branch block, however, is there anyone? None. If the left bundle branch block, however, this M will have been in V6. And in that setting, I said, if somebody is coming for the first time, especially if you have a previous ECG, If you don't have a previous ECG and they have chest pain, assume that it is new, and for your sake, and assume the person is having a heart attack. Okay, it's getting complex now. People are beginning to drift. Hello? Who is lost? If you are lost, raise your hand. Okay, about 20% of people are lost. Where are you lost? Where are you now so that we can find you? The M does not look like real M, Abi. What we are looking at is that the thing went up, came down, and went up again. 9 BM. Can we see this V1? It went up first, came down, went up, all in the same QRS before it finally continued. Now what they call M. Do you understand? Are you now found? Beautiful. Thank you. Thank you for being found. Should I do hypertrophy? Should I do hypertrophy? Should I do hypertrophy? Okay, let's do hypertrophy. For right ventricular hypertrophy, once V1 is positive, facing upwards, we say the right ventricular hypertrophy. Let's take it like that for now. Once V1 is facing upwards, we say there's right ventricular hypertrophy. For left ventricular hypertrophy, we combine V5 and V6 and V1. Once it's greater than 7 big boxes, we say there's left ventricular hypertrophy. Wait, I'll show you real life. Don't worry. You have a nice ECG. If we want to say whether this is right or this one has PVC. Sorry, I'm looking for an ECG to use. Okay. This V1, is it facing predominantly down or up? Down. Is there right ventricular hypertrophy? No. However, if it were facing up, we will say there's right ventricular hypertrophy. There are caveats, but just for now, let us just collect this one. Because write it down. We are going to meet the meat. Remember, we are going to answer questions today. Today, not today. You must read ECG. Okay. For left ventricular hypertrophy, we come and combine V1. How many boxes facing down is that? Maybe 1 or 2. V1. Can you look at that? Q. How many? 2? Yes. This one. 1. Like 2. Let's call it 2. We now come to V5 or V6 and look for which one is taller. Which one is taller between V5 and V6? V5. How many boxes is that? 1, 2, 3.5. Abi? 3.5 plus 2 is what? 5.5. So we say there's no left ventricular hypertrophy. If there's more than 7, we say there's left ventricular hypertrophy. Now, there are over 20 different ways of saying left ventricular hypertrophy. And Dr. Chidera, Dr. Chima, Dr. Amina, and everybody are going to tell me all the ways. I'm going to write it and submit it when we see on Monday. Weekend assignments. The rest of you can do it too. All right. Do we understand that now? So, let's look for another ECG. In this ECG, let me look for one. No, don't worry, we'll find some when we are going forward. We are running out of time. Now let's go to the ST segment. For ST segment, all you are interested in for the sake of this lecture is whether it is up or down. Hello? Number 1. Number 2, remember those people that I said that they are all looking the same direction? Who remembers? Inferior, lateral, anterior, and septal. 2 of them must come together and agree that it's facing up or it's facing down. So, this is the ST segment. The ST segment is between this QRS and the T. This is the place we are looking at. But to make up our mind whether it is facing up or down, we use one small box from this junction here. That is the ST assessment point. Of course, there are different, some people say use one small box, some people use 40, 60, 80. But just use one small box. So we don't use here, we use this box here. We compare this line to this line. this line to this line or to this line. We call this line the isoelectric line. If this is above it, we call it ST elevation. If it's below it, we call it ST depression. Again, hello, wake up, oh, wake up, wake up. If this is above the line, we call it elevation. Below the line, we call it depression. If there's an MI now, ST elevation, MI, STEMI. That's how we ended up with STEMI. Okay, so I think we've talked about that. And I've talked about the assessment point. This point where this QRS meets this isoelectric line is called the J point. However, we move one small box around that and we call that the ST segment assessment point. So with this now, we look at this one. Is this depressed or elevated? Depressed. If you can see, you can read an ECG. Is this elevated or depressed? Elevated. Beautiful. Okay, let me now look at this. Dr. Dafe, how did the ICD go? Great. What about this? What can we see here? Hello, what can we see here? All patients with peptic ulcer disease, pain, I'm having pain, must have an ECG done. All. Except they are 25 or 30, especially if they have any cardiovascular risk factor. They smoke, they're hypertensive, they're diabetic. All. Hello? Some people are saying, hey, ha, ha. A patient comes, PUD. Please do an ECG. ECG is cheap. It will not cost anybody anything. Are we all together? All patients with chest pain must have an ECG. Whether they are faking it, whether it is real, whether they are anxiety, whether it's anxiety, whether they ever have psychiatric illness. The moment somebody says chest pain equals ECG. The standard, we say standard and protocol, is that ECG must be done and interpreted within 10 minutes. That is the international standard. Can we see how many minutes? How many of our hospitals can get ECG done and interpreted within 10 minutes? How many? How many? Okay. So, as people that have come for ACS, I want you to work on it. Go to your hospitals. There are many hospitals where the ECG machine is locked in matron's office. Abi? It's locked in ECG room. Now you're going to go and find a way. Let them keep the key with a security man at least. When you do the ECG, we have something called WhatsApp. You can snap it and you can get it anywhere. And somebody can look at it. Abi? So it is doable, even in this country. I almost said amen. So what about this now? Is there any ST elevation we can see here? Hello? Where is the ST elevation? What? I can't hear you. Lead 2. If there is ST elevation in lead 2, which are the other leads that must have elevation too? For us to agree. Lead what? 3 and AVF. Beautiful. Some people are wondering what we are saying. Remember what we said at the beginning? I said you should write it. Lead 2, lead 3, and AVF are which kind of leads? Inferior. So we can see in lead 2, lead 3, and AVF. In V1 and V2. V1 and V2 is which one? Yeah, I think that's what we said. V3 and V4, what did we say? Anterior. Now there's argument over that. Some people say the other way around, but don't worry about that. So in this case, we will say there's inferior and there's anteroseptal myocardial, ST elevation myocardial what? Infarction. Don't miss it. A lot of patients that have inferior MI, because it's inferior, will come with that peptic ulcer. I gave a lecture somewhere. The very next day, somebody said, they told us this thing yesterday. He just did the ECG and it was MI. That's how they rushed the man in. One of the few cases that came within 1 day of MI. Caucasian, not diabetic, not hypertensive, nothing, no risk factor. 42 or so. So they said yes, yeah, Dr. Iseko said this thing. So lo and behold, they now sent it to me. I said, we rushed him to the cath lab and got it out. And we opened the blood vessel. Okay? They went back to Pakistan and brought me one funny tea like that. So instead of bringing $1. Okay. So remember this again, Abi. Inferior, lateral, and you must remember this thing. This is one of the things you must cram. When I say there's some things you must cram, These are all the things you must cram. Because if you see the S elevation in only lead 2 and you don't see in 3 and AVF, somebody is lying or somebody has collected bribe among the judges. But if 2 of them, at least 2 must agree before we now agree that yes, they have seen the correct thing and they can overturn the tribunal. All right. All right, what can we see here? This is a live ECG. This was for an Oga, the top person, NSCDC man, slender, very fit, no hypertension, no diabetes, no cholesterol, chest pain. But simply by what? Standard and protocol. Everybody must have an ECG. That's how they did this ECG. And what can you see? What was the rate? Let's start from where we have started before. What was the rate? Huh? What? 1, 2, 3, 4. 300 divided by 4 is what? What's the reading? The RR interval, are they equal? Okay. The P wave, is there a QRS after every P wave? Before every QRS, is there a P wave? Is the P wave upright in lead 2? Is it upside down in AVR? All the P waves, they look alike? Yes, somewhat so. Sinus reading, Abi? Fine. What do we say was next? QRS, Abi? Is the QRS wide or shortened? Is it more than 3 small boxes? This is one big box. This is half. So it's still half than a big box. So it's at the border, like 130. Fine. What next do we say? Is there any hypertrophy? In V1, how many boxes down is that? 1, or let's call it 2. In V5, V6, is there any? V5, which one is taller, V5 or V6? How many boxes is that? 3. 3 plus 1 or 2, 5, Abi? Is it up to 7? So no left ventricular hypertrophy. What is right ventricular hypertrophy? Is there right ventricular hypertrophy here? Yes, madam. Is there right ventricular hypertrophy? If you are writing, you will know. Is there right ventricular hypertrophy? Why do you say there's no right ventricular hypertrophy? V1 is facing down. That's all. If V1 is facing up, we say, you people have already read this ECG. Can you not see it's easy? No, it's not easy. Very easy. All patients with chest pain or ulcer must have an ECG done. All patients with chest, the amount of patients that we have seen come in and they are just hopelessly useless until they become breathless and they cannot measure their blood pressure before they now send. And the person will say they have been managing them for ulcer for 2 weeks in the hospital. 2 weeks! Before the patient got breathless, they say, go there. Then please. All means all. And you know, it's one of those things that is good for everybody. It's good for the patient, it's good for the doctor, and it's good for the hospital's finances. I mean, so the patient will pay too now. Abi, I can see as seeing of private practitioners. Abi, AGPMPN. Yes. Aha. And even the patient is not paying, it doesn't cost anything. Even the patient cannot pay. Doing an ECG, you already have the machine. It's just gel. You will see or some Abi or maybe paper. That is all. It doesn't cost you anything to save that life. Beautiful. This is one of the reasons why I started ACS. This very thing is why we started ACS. Okay, before it became bigger and we added other things. All right, the other segments we will not bother ourselves. And final, second to last, Q wave. The Q wave. A Q wave. After a P wave, the first negative deflection is called a Q wave. But there must be nothing going up. If there's anything going up, remember we say QRS. If there's something going up, we call it something else. Call it an S wave. Yes. Okay, don't worry, I'll show you. I don't have one. Call me, sorry. Can we see there's a deflection here? Hello? This is P wave, and there's a deflection going down here. Is it the first deflection after the P wave? Hello? Is it the first deflection? The first one went up, Abi. So therefore, this is not a Q wave. In this, our patient now, who was, yes, an Indian woman, I remember her, 2015. Is there anything going up after the P wave? It just went down straight. So this is a Q wave. Q waves are just like ST segments. You also need to see them in the same region. You are seeing that Q wave in V3. Where else should it be? If you see Q wave in V3, where should you see it? What? V4. Some people are listening. Other people are just wondering, what are we talking about? Hello? V4. If you see Q wave in AVF, where else should you see Q wave again? 2 and 3. So I need just 2 people to agree. Okay? Even this one is not technically, may not be a Q wave because there's a small, can we see this small one that comes up? So therefore it disqualifies it. So you can see this extensive myocardial infarction. Extensive. Okay? I remember she went abroad, went to India, triple vessel disease. She refused to have surgery. She said she will get divine healing. I don't need to complete that story. And finally, T wave. I will not talk much about T wave, except T wave should be facing upwards or facing the direction of the QRS. And if it's facing the other way, be worried that something may be wrong. Period. So I think it's fair enough for this level. All right. So now let's start reading ECGs. Hello? I'm going to call you, whether you say hi or not. I'm going to call you. All right. Pick somebody. Pick him. Sir, can you help us? No. Did I call you sir? Look at this man. The man behind him, that's the sir. Sir, can you help us? Let's try. Thank you very much, sir. I'm very happy that you participate. Thank you, sir. So we first start with the rate. What's the rate, sir?
100, sir.
100, perfect. What's the rhythm?
It's normal.
Normal sinus rhythm.
Normal sinus.
So that's how you'll be writing it. That's how you're writing your report. So when you sign your name, you sign it well. Yes. What's the next thing? After rate rhythm, yes. P waves are already inside the rhythm. QRS, Abi?
Yes, QRS.
The QRS, is it wide, narrow? Is there anything wrong with QRS?
It's narrow.
It's narrow, so it's normal.
Normal, yes.
Is there any left ventricular hypertrophy or right ventricular hypertrophy? Right ventricular hypertrophy is what? In V1. Is V1 facing up or down? Down. So is there right ventricular hypertrophy? No. Left ventricular hypertrophy, what did we say? V1. I normally add V2. V1 or V2 or V5 or V6. So V1 is how many boxes? 3. This one, which one is higher?
V6.
1, 2, 3. So we call it 6 boxes, just for argument. But really there's LVH here. Okay. ST segment. Any depression or elevation?
That is a depression.
Where?
At I can't see.
Where did you see the depression, sir? Is there any place where this ST segment is below this line? Is there any place where?
V3.
V6, Abi, is below the line, Abi?
Yes.
Where else must we look at that ST depression again to be sure that it's telling the truth? V5. Where else again? 1 and what? AVL. Beautiful. So here we can see there's also depression in V5 a little bit. Okay? In 1 and AVL, is there? Not really. But there's T-wave inversion. And there's T-wave upside down in 1, AVL, V5, and V6. I think we can all see that. So T wave typically should go in the same direction as the QRS, or should be facing upright in most cases, except AVR. Okay? So, sir, you now sign your name on that ECG and say that yes, you came to ACS. Thank you so much. Can we give a round of applause? Thank you very much, sir, for obliging us. Okay, so let's go to another one. All right, who is bold? Give him this doctor. Give him, Dr. Okole. Time you work in him also, you should have learned this thing. I remember. The camera is on you.
Oh.
So go ahead.
The
rate.
1, 2, 3, 4, 5, 60 plus 1, 2, 3.
Okay, so here is 1, 2, 3, 4, 5.
60.
The rate is about 60, Abi, correct. So the average of them, Abi, 60, correct. Read him.
The up, down. The P wave.
Dr. Mr. Victor, I need a jotter, please.
The P wave is upright in lead 2.
Where are you seeing P wave? This is not Ali and the Angel.
Okay, there's no P wave in
there's no P wave.
in
Where did you see it?
It's not there.
It's not there, huh?
It's not there.
AVR, can you see it? Are all the R intervals equal? You remember you had to even do the average now?
Okay.
From here to here, how many boxes are in between here and here?
3.
What about here?
5.
Already it's not equal. We can see all of that. When R intervals are not equal and there is no period, what do we call that?
It's not a sinus.
Check that your book, that thing we wrote. No, Flutter will say regular, multiple P waves. Check what you wrote. This is why I say you must write. This is time we're using that what we wrote. If you wrote now, ECG will be easy. If you did not write, my prophecy will come to pass.
Atrial fibrillation.
Atrial fibrillation, don't be afraid. Let's clap for him. Yes. So what else do you see again? We now jump from there to QRS.
There is the QRS is wide in V3. It's okay. No,
it's not wide.
It's just one box, so it's normal.
It's about normal. Yes.
It's normal. Okay, so there's normal
QRS interval.
Interval.
Okay, is there right ventricular hypertrophy? V1. Is V1 up or down?
V1 is down, so there's no right ventricular hypertrophy.
Perfect. Left ventricular hypertrophy, unko?
It's
1, 2,
3 plus
1, 2, 3, 4. It's more than 3. 4. 7, Abi. 7 and above. What do we say?
Left ventricular
hypertrophy. Okay, fine. ST.
There is ST elevation in V3.
Okay, maybe.
It's also in V2.
Okay, now V2 and V3, are they together?
Okay.
Check your book, check what we wrote before. If you have only acceleration in V2 and V3, and no other place, both of them are lying from different points of their mouth.
No,
nobody is backing them up.
There's elevation in 3 and 4.
4 is not elevated though. Okay, so let me say it this way. In this chest is V1 to V6, elevation must be more than 2 small boxes. I forgot to say that, my bad. It's written in the slide, but I forgot to say it. In V1 to V6, elevation must be more than 2 small boxes for you to say there's elevation. And in the other one, it's just 1 small box. In all of these ones, 1, 2, 3, AVR, AVL, AVF, just one small box. While in these ones, it must be up to 2 small boxes. So in that V4, it does not qualify. So you only have it somewhat here, yes, but it's not, this one no follow arm, and this one no follow arm. So we just call it non-specific or benign early, don't worry. This thing.
So the one that is going up after the QRS complex, is that not the ST segment?
No. When did we say we are deciding whether ST segment? Remember, we pointed to a point, and we said it was the ST assessment point. One box after where the QRS comes up. So as the QRS is coming up and is meeting with this, that is somewhere here. One box after, which is here, that assessing whether there's ST segment elevation or not. Here. The same thing there. You don't come now and say this place is elevation. No. You check, this is where he reached here before he started. See how he went? At this point he turned. That's where this one has started going off. One box there, that is the point you check your ST elevation. That is where you test. You don't test the entire place and say, remember, ST assessment point is critical. It is that point you are chasing, not the entire segment. Okay? This is a very, it can be challenging even for cardiologists. There are times you cannot swear in between what it is. And in that case, if this patient has chest pain, you must do a troponin. You cannot assume. Like I've said it now. If the patient has chest pain and is in my hospital, you must do a troponin before you go forward. Thank you very much. Let's give a round of applause. All right. We are more. Okay, let's leave it alone. Let me leave it alone. Aha! Beautiful. I know this guy. Works in a telecoms company. Yes. Came to my office. Whether they say blood pressure was 130/98. As soon as I saw the CCG, I say it's a lie. There is something else wrong with you. I can see it. The man said, you're a prophet. How do you know? I say, yes. Go and pay extra. I'm joking. Yes? Anybody. Anybody. Yes, give her. Thank you, ma. Go ahead. I trust you. I believe in you.
Sir, please, I have a question.
Okay, go ahead, please.
Yes, sir.
You see answer it, oh? No, other question or not.
So it's the ST elevation you're trying to explain earlier. I didn't get what you were saying about the next box.
Okay. Can you see this diagram? We said that as this Q wave is coming up, this is the Q wave, Abi, or S wave rather, coming up here. As it's coming up here, it meets a junction before it starts turning. We take one small box. Can you see this place? That is the point that we use to assess the ST segment. Do you understand? So if you look at this ECG now, and we are deciding, is there elevation or not? In some cases, it is like this. It is going up, it is concave upwards. But that point that it changed is still very low and almost at the same line. Those places are not particular. But this is a difficult thing sometimes to tell. That's why I said it's difficult even for us. Sometimes we have to ask each other to agree. One of the key things you will use is what we try to use. Is there any other person in his group saying the same thing? In this case, it was only that V3 that was saying elevation. The V4 did not agree with it. So that is why we said very likely that it's not anything. Okay, do you understand that a bit? So you use this. This is the diagram we are using to decide. There are some cardiologists that believe we should use this J point rather than this place. Both of them are correct. If you use this one or use here to decide whether the ST is elevated or not. So now, can you answer our question? I answered your own now. Where do we stop? What time is prayer? What time is prayer? 15 minutes? 1:30? What time is prayer? Please, can somebody tell me what time is prayer? 1:30? Don't tell me because you are hungry. 1:30. You are sure? She looks genuine. Okay. Where was the one that we gave her? This one, okay. She wish she squeezed her face. You are going next. Yes, yes, I believe in you.
The RR interval is, the rate is 75 beats per minute.
Correct.
There is normal sinus reading.
Normal sinus reading. Talk. Let it flow. QRS.
I'm not sure.
QRS, is it wide or narrow?
Okay,
Is it wide or narrow?
It's normal.
It's normal. It's not wide. Correct. Is there any right ventricular or left ventricular hypertrophy?
Oh, yes. V1 is facing upwards.
Perfect. Right ventricular hypertrophy. That's
So
why I
there's
told the
right
man that there's something
ventricular
wrong
hypertrophy.
here. 32 years old. He's now married.
But there's no left ventricular hypertrophy, sir.
No left ventricular hypertrophy, but there's right ventricular hypertrophy.
Yes,
Now, is there any Q wave?
I don't know.
You got
I don't know, sir.
Q wave. Is
Like,
there after the P wave? Is there a negative inflation that comes first after any of the Q waves?
No, sir.
No. So no Q waves, Abi?
Yes, sir.
T wave. Are the T waves upright or facing downwards?
Okay, in V3 and V1, V4.
V3 and V4 are related, Abi? Where
Yes,
else
sir.
can you see it upside down? What of V2?
V2 and yes, sir. V2 and V1.
V2 and V1. Is there any ST segment depression or elevation?
Yes.
Don't worry, speak. Highest as I will laugh.
Sir, ST.
Is there any depression or elevation in any of the leads?
Sir, I don't know.
No, you must know. See the line. This is lead 2. This ST, is it low or normal, the same line? Is it low on the same line? Is it on the same line?
No, sir.
It's not on the same line?
Which?
Here like this. Are they all around the same line?
Okay, yes.
Yes, now. When we come here, Uncle, is it on the same line?
No, sir.
No, sir. So there's
So
depression
it's
there, not so?
depressed. Yes, sir.
V3, which one should also show the same thing?
V4, sir.
Is it showing the same thing there?
Yes, sir.
Correct. But there are some that are close to V2, Uncle. What do you think about V2? See the PR, see the TP. Is that ST up or down?
It's down, sir.
Down. ST depression. V2, which other one should you check?
V1.
V1, Uncle?
It's down,
Down. So you have ST depression what? V1, V4 to V4 and T wave inversion in the same place. Okay?
Sir. Yes, sir.
Aha.
Thank
So
you,
you
sir.
have right ventricular hypertrophy, normal sinus rhythm. You have T wave inversion showing that heart is struggling. The right ventricular part of the heart is struggling. So I told you there's something wrong here.
Yes, sir.
Sign it. Look away while they are paying. Let's clap for her. Well done. All right. Oh. She announced it, Abi. Professor Damachi has some comments, but actually he will have to run. He has a very important thing to meet up with, so he wants to make a brief comment. Please let's just listen carefully.
Yeah, good afternoon, everybody. I think I like this audience. They are so attentive, they are motivated, and they showed interest to learn. Remember what I said yesterday? You should learn, relearn, and unlearn. I'm sure now we are unlearning some things that either we were thinking, so we have to every time unlearn the wrong things that we've learned wrongly. We must unlearn it. So very nice audience. I'm happy to have given my small contribution to what cardio care is doing. Cardio care is helping us. This is valueless. It's valueless, not what you paid. The thing you are getting is really plenty. It's a lot. All right? So I think we should give a round of applause for cardio care once again. And then on ECG, I want you to remember one thing or two things. Anything you see on that ECG tracing, you are talking of a repetition of PQRST. That's unit of a ECG. There's nothing new. It's only the way the leads are looking at the heart. So ECG unit, ECG tracing unit, PQRST. So even if you look at V6, or you look at lead 1, or you look at lead V1, it's still PQRST. The only thing is the resultant direction of the QRS complex that might change, or the P wave, or the T wave that will change. But those things, those components are always should be always be there. If they are absent, something is wrong. Thank you very much.
Thank you very much, sir. We really appreciate it. He's come all the way from Jos to attend this, to grace this occasion. Can we give a standing ovation for him? Can we standing ovation? 30-something years in the practice. It's not beans. Professor of the arts. We thank you very much, sir. We appreciate you. Mr. Lokela, please do the needful. The plaque, is he here? Bring it now. Please, sir, we have to give you something, sir. Mrs. Iseko, I hope. Thank you. Sir, please come, sir. I want to give you a small plaque, just recognizing, to add to the many awards on your table. Who is coming with it? Who is coming with it? You can all sit down, please. You can all sit down. Thank you so much. Those of you that are in postgraduate training, you will meet him in exam. And if he remembers you, you will try.
I'm not a tough examiner.
Very nice examiner. He will just be laughing. Is that what you say? He will just be laughing. I need somebody to help me. Okay. Sir, please come, sir. On behalf of Cardio Care Hospital and the Limi Hospital Group, I should come down. Maybe I should come down. Okay. On behalf of Cardio Care and Limi Hospital Group, oh, fine. Thank you. And the Limi Hospital Group, we want to give you this in appreciation of your remarkable presentation, your enrichment of the entire program, the 7th ACS and the first inaugural LM Iseko Memorial Lecturer. We appreciate you very deeply. The tips and tricks of cardiology that you taught us will go a long way in our lives. And over 500 people that are registered and the several hundreds online here in Nigeria and beyond, we will never cease to appreciate you for what you have done in training me first. Then, before we could organize this, and in now honoring our invitation, we can never be more grateful. Thank you so much, sir. We are grateful, sir. Thank you, sir. Thank you, sir. Okay, we will do a few ECGs, then we'll go on a break. Can we do a few more? Or we should go on break? Question. Somebody say break. Yes, please, question. Jude, please, question. Jude, microphone. My slides, please.
Sir,
it's actually almost time for most, so we have about 3 minutes or 5 minutes. So we'll just do that, 1 or 2 more. Then we'll go on break. While you're on break, if you're not going to the mosque, sit down, scan to refer, and open your workbook. There are ECGs there. So you are going to make an attempt to answer them. Make an attempt to answer them. So when we come back from the break, I will just be answering questions. This is your best time. If you do not practice after this, you have wasted your time. I promise you. You must practice. And the people that will know it for the rest of their life are those that after practicing today, we catch somebody, even if they're 3-year-old son, and just be teaching him. Just be teaching. Once you teach somebody, you will never forget it again. Okay? So, by the time we go on break, while we are sharing lunch and everything, take some time to either do it online or use that. If I use the book, don't use it online. Online is for your personal home use. Use the book and answer it. Then when we come back, I will now answer any random question before we go into MI and then ACLS. ACLS and MI. Yes, sir.
Does all ST elevation mean myocardial infarction? I think from the previous slide, I think there was a ST elevation.
Not all ST elevation means a myocardial infarction. That is true. However, when you have ST elevation in contiguous leads, you should strongly consider myocardial infarction. Dr. Inuwa is going to take us myocardial infarction, and she will tell you what else you must add to that thing to help confirm your diagnosis. But if you have ST elevation in the setting of chest pain or myocardial symptoms, you should strongly consider that that is a myocardial infarction until proven otherwise. It is better for you to assume that an ST elevation is myocardial infarction than to assume that it is not. So if you see ST elevation and you see it in those, remember I told you to cram those leads. If you see it in more than one lead that is grouped together, ST elevation MI until proven otherwise. Why is this important? ST elevation MI has almost an 80% mortality. I'm telling you. Within the first 1 hour, 50% will die. The remaining that will make it to the hospital, some will stay 2 weeks, 3 weeks, ulcer, pneumonia, different things. Those ones, within 30 days, another 50%, 30 to 50% will die, 30-day mortality. Before even the ones that now get to do, now even the ones that get to do PCI, it's not as if mortality is completely gone completely, especially if they come late after 3 hours or after 6 hours or after 12 hours of the chest pain. So you can see how the patient you are looking at is a patient that came, was it last week? Managed for ulcer for 2 weeks in the hospital here in town, ulcer, with breathlessness. Then somebody now brought him. When he came, he had come too late. The creatinine was so high, he was already in kidney failure. Even going to try and do the surgery for him will be too high a risk. He did not make it. He did not make it. Because somebody was managing, nobody took time to do an ECG. Do you understand? And even if they did the ECG, nobody took time to look at that ECG and to see. So it's better to have heard, especially when you now start seeing patients hypertensive, they are diabetic, they smoke, and the ST elevation is in contiguous leads. Those leads that are looking at the same area, you should assume it's an MI. Now, if it is not an MI, oh, thank God. There are some cases that is not an MI, maybe myocarditis, maybe other things. But you must never miss an MI because it is life or death. And in this day of court suit and the like, you can be sued. Because every doctor and every nurse is supposed to be able to identify it on the monitor. If I leave a patient with you in the ICU or in the ward, and patient's on the monitor and the thing went up, and you cannot tell, they are just telling me pulse, blood pressure, respiratory rate, I will not be happy with you because you should be able to tell that something is wrong. Okay? And we'll go to ACLS. Dr. Dafe is standing by.
Sorry, sir. My question goes, what are the key features that will determine if AVR is either inverted or erect? Because at times it could be very challenging.
I don't understand.
AVR.
AVR.
If it is erect.
AVR is always upside down.
All cases?
All cases. If AVR is facing up, two things have happened. Or rather, the most common thing is that the leads were placed wrongly. Somebody placed left hand on right hand or left leg on right leg or something. Or there's a condition. If there's some right ventricular infarction or sometimes in left main obstruction, if you now sure that you put the leads in the correct place, yes, and you see CAVR up, then you are thinking of right ventricular infarction or left main obstruction. There are some other things you need to go ahead. But otherwise, if AVR is pointing up and everything is pointing up, chances are that what you are dealing with is wrong lead placement. You put right hand on left leg or right leg on left leg, you put it. So sometimes you can see, I think this is wrongly placed, send it back. Go back and redo it. Some people even refer with plenty diagnosis. I said, come on, this is wrong. Go back and redo it. And the patient is already panting. They call you up at 2 a.m. and say, doctor, you must see me this night. And I said, this is a wrong ECG. We now do it properly and everybody calms down. Okay, so that's it.
What about in dextrocardia?
Dextrocardia too possible. But that one you should have already known from your clinical examination. That is why you must take. ECG is not a standard. Remember, like Prof said, history and examination. This is just adding up. So before you even go to ECG, you already know it's dextrocardia. Well, assuming that it was a normal, I might just come to ECG, I'm going to look at ECG like this. Okay. All right. Final question. Is lunch ready? Okay. Or should we just continue moving stuff now?
Sir, my question is, are there conditions where these patients, some patients may have a U wave? Because I know some textbooks will always put U
yes,
wave.
there is, but we're not talking about, no, keep that one away, please, for now. Just learn this one first before we enter that one. There are many things I've not talked about ECG. Many. But this is the one you need to survive today. Learn this one first. Then we can move forward. Some extra will teach you the next one. The next one we're going to teach is MI, recognizing chest pain. What kind of chest pain should you be running? And which one should you relax? Then we are doing ACLS. When you are in the emergency room and you are looking at the ECG, what should you do? Should you shock? What drug should you give? Because that will be life or death. You don't have time to call anybody. So beside your BLS, which we learned yesterday, the next step is ACLS. You are going to learn it today before we close so that you can go and be confident. And we have about 4 consultants or 5 consultants that will be around. In case you don't understand, they can answer you small. Dr. Olalekan is at the back. If you have a question you are too afraid, you can just call him and ask him, oh boy, I don't understand this thing. He will show you on your book.
So my question is, do we have other ECG findings that are suggestive of myocardial infarction apart from ST segment elevation and bundle branch block you told us?
Very good. Next lecture. When we are doing chest pain and MI, Dr. Inuwa will take you on the different ways you can do it. All right. We'll be taking a break now so that people can go and pray. In 20 minutes time, that is 1:50 or 1:45, lunch will start being served. And then please remember where you are sitting, because when we want to share certificates at the end, we will share it so that we have over 500 people, so we don't have a mess in sharing your certificates and your CMEs. So please, we will just share it. So they've taken your names, they've written your names by the table that you are on, so that when we are coming back for the final collection, you will do so. Let's go straight for Juma. For those that are praying, for those that are not praying, please open your book and start answering. There's a mosque just down this road. There's a major mosque here, and I think there are places to pray inside this compound, if I'm not mistaken. So thank you very much. Short break, 40 minutes break. 40 minutes break. We'll reconvene by 2:10. 2:10. But by 1:50, 1:45, food will begin to be served. Thank you so much. Clap for me now. Yeah, don't try. Thank you.